Any discussion you want?
I'm going to talk a little bit about rehab of the cuff, both post-operatively and non-operatively. So both topics are pretty extensive. You could spend a lot of time talking about each. So I'm really just going to hit some highlights and be heavy on the evidence-based approach, and what's out there recently in the literature. So first we'll talk about post-operative treatment of the rotator cuff. And first, just briefly, we'll talk about arthroscopic tendon debridement. So not an arthroscopic tendon repair, but just the debridement, whether it's coupled with distal clavicle excision, chromioplasty, things like that. Basically, there's really no restrictions or precautions following this particular surgery, as there are with the rotator cuff repair. So really, the only restriction is lifting heavy things or keeping the weight limit down on what they're lifting. So the patient's pain level is really what's going to dictate how well they progress through, or how quickly they progress through, the rehab process. You can see a patient 4 or 5 days post-operatively after arthroscopic tendon debridement and some other things involved, and they've got pretty good range of motion in their shoulder, pain maybe at end range of motion. They've got a pretty short rehab stint. And you can have a patient goes through the same surgery, they come in and it's really painful, it's stiff, they're not sure what to do, and so that sort of dictates how well they progress along that plane. So following that stepwise progression in rehab and just addressing the pain, increasing range of motion, working on strength, and then getting them functional again in what they want to do in the future. So now we'll kind of go through the rotator cuff repairs, as we all know, the open procedure or arthroscopic, and I understand that the protocols from surgeon to surgeon differ, but I kind of tried to just get a general sense of what each stage reflects. So obviously, the first 3 weeks in stage 1, typically we're not going to see patients following a rotator cuff repair. They're going to be home recovering, an arm in a sling, but occasionally, if the repair isn't very extensive, we might see them a week after surgery. And at that point, it's just passive range of motion, getting early range of motion in there, not really trying to disrupt that, tear it on, and get them to that next phase. So around 3 weeks typically is when they'll come in for an evaluation. This time I think really gives the clinician a lot of insight into the recovery and how it's going to play out down the road. In the first week or two, if you've dealt with a lot of shoulders, you can really get a sense for how that shoulder in a week or two is going to respond, even down the road. Are they progressing well along that pathway, moving like you would expect them to? Are they moving a little bit ahead of schedule, and you're going to kind of need to hold back the reins in the future, and not allow them to exceed those limits that are set forth by the protocol? Or are they just really, really tight? That's going to be a big thing you're going to need to address now and probably later on to the next stage. The precautions I'm sure everybody's aware of, the 40, L1, and 140. And we're also pretty limited in this stage because we're trying to protect the repair in our mobilizations. We can only do grade 2 mobilizations, which are fairly limited mobilizations. But you can help with relaxing and the muscle guarding of the patients. And oftentimes early on they're still pretty tender over the joint line, so you can't really get a great glenohumeral glide there, or a mobilization I should say. But if you move a little distally away from that painful spot, you can still get an effective glide of the glenohumeral joint that can be helpful in reducing pain and helping to increase that passive range of motion. So I think too that this is a great time to identify those compensatory patterns that patients develop following rotator cuff repair. The classic one is the scapular elevation. So if you've got them doing active assisted range of motion, whether it's supine with assistance of a cane or a bar, or whatever it is you're using to do active assisted range of motion, you can sort of detect those patterns, that shoulder elevation. And if you address that even that early, before active range of motion on land begins, you can really save yourself some time and effort later on down the road. And if you've got aquatic therapy at your clinic, that's a phenomenal supplement to what we do in clinic, because a lot more range of motion. They can move their shoulder, and I think more than the benefits of the range of motion and the function, but it helps to build their confidence, because a lot of times the patients will come in, they're going through this phase, I can't even raise my arm up here. Is that normal? Shouldn't I be able to raise my arm a little higher or a little further? And they get in the water and they see that they can do that. It's just a matter of this progression. So As far as home exercise is concerned, the stretches that I like to give my patients, I like to be really, really, really passive, so they don't have a chance to really activate any of the muscles. So the three I like are supine, using a cane or a stick for external rotation, and then abduction and flexion, as this picture illustrates. Either passively moving that arm with the other arm out in front of you for flexion, or out to the side with the assistance of the other arm. Or if you have a chair that rolls at home or they're at their desk, they can just plant that arm and go back or out or whatever. But really letting that shoulder relax. And a lot of times patients ask me, well, are we going to use pulleys sometime? Are we, aren't I going to get a pulley thing? Well, I'm not a big fan of pulleys, especially in this stage, because every time I've ever seen a patient use a pulley, I see this. They're doing this whole thing. That tells me two things. One, that they're using their muscles. They're engaging their muscles, so they're not completely relaxed. So they're not getting as much of a stretch as they could if their muscles were relaxed. And two, they're feeding into that compensatory pattern. They're strengthening that upper trap, and they're sending signals to it that, hey, it's okay for you to take over the work for the anterior deltoid, and the anterior deltoid never gets stronger. So if you knock that out of the way early on, again, saving your time down the road. Scapular clocks to sort of get those parascapular muscles engaged early on. Isometric internal and external rotation, again, just to get the cuff sort of mobile a little bit. And then active assistive motion, as we talked about, whether you do it in supine or, if they're doing really well, sitting, standing, that sort of thing. So in the third stage, typically they've had the follow-up with their surgeon, right? And they come to see you, and now, everything on that prescription says full, and all that stuff, so they think, all right, here we go, now we're going to get to the real stuff. But I always like to caution them about two things when they come in for that follow-up visit after seeing the surgeon. One is, focus is still going to be on range of motion. That doesn't go to the wayside. We've still got a long way to go to restore that range of motion, and that's our number one priority right now. We don't want that shoulder to get stiff. It's done great so far, or maybe it hasn't. And, the range of motion is our number one priority. So isolated glenohumeral joint motion is the big thing. Scapular mobilization. And then at this time, as far as our stretches are concerned, this is where I would, introduce the whole wall walking thing. Right? So up to the front, out to the side, that whole business. And then with strengthening, so again, here if you haven't addressed those compensatory patterns early on, you're definitely going to see it now. So, along with advancing their stretching program, one thing I have them do when they come in for that follow-up visit when they enter this third stage is I take them out to the gym and put them in front of the mirror, and I say, raise both arms up at the same time. And, inevitably you see this whole thing going. I say, well, what do you see going on the shoulders? Well, this shoulder goes up higher. Okay. So then I use that as sort of a teachable moment to tell them why that is. The upper trap's taking over. It's a close muscle. It's strong. It's trying to do the job that it's not designed to do. It's designed to elevate the scapula, not to raise the arm up. That's the job of the anterior deltoid. So I have them actively set that shoulder down and then try and raise their arm up until they see it rise. And they say, wow, that's tough, and I can't even get my arm up that high. Great. That's what I want, because we're isolating the anterior deltoid, not letting that upper trap kick in. I always tell them quality of motion, not quantity. They're all interested in getting their arm up high, but if they do it the wrong way early on, they're never going to get that motion down the road. And then strengthening, obviously in good form once they get the range of motion back. And this is, what a lot of us do a lot of the time at this stage is strengthening, internal and external rotation, PNF patterns, both D1, D2, against resistance, rows, Ys, Ts, and arrows, and then flexion, either starting off in supine if they really don't have a great deal of flexion sitting or standing. You can just increase the resistance as they're in supine and then get them to a position where they're working against gravity a little harder once they get stronger.
What's arrows?
Pardon?
Arrows?
So Ys, Ts, and arrows are typically done over a physio ball or something. So Ys, T's, thumbs up, and arrows back here, just for lats. Same deal standing or doing this thing. No difference. And then you get to the final stage, hopefully, and you've set this great base of support for that shoulder. You've got full range of motion, you've stabilized the cuff, you've worked on the parascapular muscles surrounding it, and now it's time to find out how well it holds up to what they want to do, whether it's back to work, whatever their activities are, recreational sports, professional sports, whatever that may be, needs to be tested out in the clinic before they go about. So you can identify, it didn't hurt before, but, in my backswing I notice I'm a little restricted, or I get some pain here, or, they go back to throwing it and they come back and report these things to you. This is sort of the fun part where you get to, they go out and they try these things, and they come back and say, hey, and you think through it with the patient, you talk to them, so what is it, that you're doing? Oh, it's when I'm doing this, and it's a very collaborative, as the whole rehab process is. It's a very collaborative part. And then, lastly, in the post-operative treatment, throwing the total shoulder arthroplasty up there. So the reason I have this in here is because the protocols and the limits that we have following a total shoulder arthroplasty are not because of the prosthesis. It's because of the subscapularis that needed to be cut in order to perform the surgery and then repaired. So the prosthesis is fine. It's great. It's the cuff that has been compromised, and why we're going through the process that we do, just like with a regular open rotator cuff repair. So their recovery is really dependent upon, as Dr. Spear talked about, the viability of the tissue. Is it someone who's had severe osteoarthritis in the glenohumeral joint, but they've been working and doing everything they've done before, but just with pain? So typically their tendons are probably going to be good, viable, healthy tendons, nice and strong. So there's no reason they shouldn't get back to full, or near full range of motion, full strength. But on the other hand, if you've got someone who has had an arthritic shoulder for years, and they've really had limited use of that shoulder, and the muscles have atrophied, the tendons sort of dried up, and then you kind of don't know what you're going to get. The pain's been taken away by the placement of the prosthesis, but now let's see how much function you get back in the shoulder. So any of the rotator cuff repairs, whether it's the shoulder arthroplasty or the open or arthroscopic rotator cuff repair, it's just building that bridge, making that gap, protecting the repair, restoring full range of motion, building strength, and returning to function, and hopefully giving them some way in the future to maintain some good joint health, not only in the operative shoulder, but the opposite one as well, so they don't end up with the same problems down the road. Now, the literature in this area, post-operative rotator cuff rehabilitation, is pretty slim, relatively speaking, to the literature out there on the shoulder. But most of the stuff that's being done now is looking at how far we can push the limit with starting earlier, and getting involved sort of almost immediately after rotator cuff repair. Now, these are very small sample sizes, not really good research designs, but that's sort of where the literature right now is tending to be, is how early can we get involved without disrupting the repair. So now, maybe a little more interesting topic, the non-operative evaluation and treatment of the rotator cuff repair, or tear, I should say. So, obviously the evaluation plays a real important role. The history that they give you gives you a lot of insight into what's going on, what might be involved. Their active range of motion, you can detect any compensatory patterns if any are present. Maybe give you an indication of what particular tendon might be involved. As Dr. Spear mentioned, most oftentimes, if not all the time, it's a supraspinatus. And then also gives you a chance to look at the scapular thoracic mobility and the scapulohumeral mobility, and whether or not that's where it needs to be. And then passive range of motion, a lot of times is going to be greater than active range of motion, because you don't have that activation of the cuff or push, or the non-activation of the cuff involved, and you can stabilize that joint as you move it through the range of motion a little bit better. And this is also a great time to detect the capsular mobility of the shoulder and determine if there's any deficits, tightness, or looseness in the capsule. So we've got this great new way of measuring posterior shoulder tightness, which is one of the problems that leads to impingement and then consequently rotator cuff involvement. So Tyler et al. in 1999 first put out this new method of detecting or measuring posterior shoulder tightness. He went on then to validate this method, prove that it's a valid and reliable method for measuring posterior shoulder tightness, as well as even just this year he put out a study showing that posterior shoulder tightness, or decreasing posterior shoulder tightness in patients with shoulder pain, was directly correlated with reducing their pain. But increasing posterior shoulder mobility did not correlate directly with increased internal rotation. So, when you're looking at, treating the posterior shoulder tightness, it's not so much focusing on, as this study tells us anyhow, not so much focusing on increasing internal rotation as it is working on the posterior capsule and gaining motion out of that, whether that be through mobilizations or through, stretching out into internal rotation. But the goal shouldn't be to gain internal rotation, it should be to stretch out the posterior shoulder. So this is the evaluation method as he's described in the literature in 1999. So patient lies side-lying on the uninvolved side. The hand is underneath the head to create a level spine. Hips and knees are flexed to 45 degrees, and the clinician stands on the opposite side, stabilizing the lateral border of the scapula, and the other hand grasps the proximal end of the forearm, and then the arm is slowly lowered down until a firm end feel is felt. And then that's where the measurement is taken. Now, when he first described this measurement, it was taken from the medial epicondyle to the plinth. So that was the measure that he took to look at posterior shoulder tightness. Maury Colbert et al. At Nova Southeastern University just did a study looking at measuring it with a inclinometer. So it'd be easier to use than, getting an extra hand in there, because you need another person in there to measure the distance. Strapping the inclinometer to the mid-humerus and then gaining the angle that way. And he was able to show that between the two, you need an intra-class correlational coefficient of 0.90 or better to determine that this new measuring tool, whether it's a goniometer, tape measure, or inclinometer, is as same, if not better, than what you previously measured it with. So he showed an ICC of, I think, 0.978. So a very good, reliable method to replace this method and make it a little bit easier. Obviously, strength is a key ingredient in the evaluation. You can isolate a particular rotator cuff muscle that's involved, is it painful, weak, and then really being thorough and looking at the surrounding musculature too, not just that which affects the glenohumeral joint directly, but those surrounding it as well. And, one thing to note too is that I think most of us were probably taught, it's in the textbooks, that supraspinatus is responsible for the first 15 degrees of abduction in moving the shoulder, but that really came about from 5 or 6 studies that were done in the mid to late 90s that showed increased EMG activity in the supraspinatus with abduction from 0 to 15 degrees. But what really is probably going on there is that supraspinatus is stabilizing or bringing that humeral head into the glenoid at that point, and that's why we're seeing that increased activity, and which allows the lateral deltoid then to move it. So that could be an important thing when you're evaluating strength. If you look at, that's painful. Well, and there might be some supraspinatus involvement there too, but keeping in mind that the supraspinatus isn't responsible for that, it's actually stabilizing the cuff while the lateral deltoid is moving it. Palpation, and a special test here, the transdeltoid palpation, or the rent test. It's only really good for detecting full thickness tears in the rotator cuff, which most of us aren't probably going to be treating conservatively. But if you're taking advantage of direct access and a patient comes to you, this would be a good test to either rule in or rule out a full thickness rotator cuff tear, and then refer on appropriately. So this test demonstrates a sensitivity of 96, a specificity of 97, and a positive likelihood ratio of 32, which, if you know what those numbers mean, that's astronomical. I mean, that's just out of this world as far as statistics are concerned. That's a really good test. And then obviously just palpation of the different rotator cuff tendons with the exclusion of subscapularis because you can't palpate. And then we've got all these special tests. I mean, these are just for rotator cuff integrity, and I don't even have them all listed here. I mean, you've got the bear hug, the modified bear hug, and all these here that have been shown in the literature. You know, there's sensitivity has been proven, specificity, likelihood ratios. They're all good tests, but cluster signs tend to be more indicative or sensitive, specific to detecting rotator cuff tears than just one single test. So you got an individual who's over the age of 65, has pain at night and pain with external rotation, you have a positive likelihood of 9.84 that there's a rotator cuff tear. If there's supraspinatus weakness in external rotation, and either a positive Hawkins-Kennedy or a positive Neers test, then you've got a 98% chance that there's a rotator cuff tear. So those are pretty significant. So these cluster signs are a lot more reliable than any one test that you can do to detect rotator cuff tears. And then, you know, this is the key point, making the bridge between what you've gained in your evaluation and how you're going to approach it in your treatment. So identifying the cause. Is it age-related changes, you know, trauma, or impingement, either internal or external impingement? And this is what I'm going to spend a little bit of time talking about now, is impingement, both internal and external impingement. So Dr. Spear already went into some of this, so I'll just touch on it briefly. But external impingement is classified sort of you know, external as in outside of the glenohumeral joint. So the classic impingement, outlet impingement, Neers impingement as it's described by Neer, and that's just the superior migration of the humeral head, pinching those structures underneath the acromion there. Presentation, as Dr. Spear mentioned, typically, you know, pain anterior, laterally, things of that nature. And then internal impingement, internal meaning within the glenohumeral joint itself. Now, in this issue of the British Journal of Sports Medicine, there's two really good articles on internal and external impingement. One's a literature review, pretty extensive, and the other one's an actual study. So some of the theories behind what's causing this internal impingement, one is you know, a tight posterior capsule. As we talked about how to measure that early on, I put that in there because that's a really important thing to look at, specifically when talking about internal impingement. And this is really seen a lot in baseball pitchers. You know, that late cocking phase, they get pain posterior and say, you know, it really hurts when I get back here. Well, the thought process behind that is that, you know, you need a lot of force to decelerate that arm as you're coming through and your follow through. So that creates some trauma to the posterior shoulder, eventually leads to scarring down the posterior shoulder and tightening of that posterior shoulder capsule. So then that tightening of that capsule then pushes that humeral head anteriorly, maybe superior a little bit, and demonstrate a little bit of laxity in the anterior capsule. So you get this compression of the supraspinatus, maybe even the infraspinatus, in that posterior superior glenoid rim as it rotates into external rotation at 90 degrees of abduction. And you can also get involvement of the posterior superior labrum with this as well. So in this little schematic here, you've got the shoulder abducted and externally rotated to 90 degrees, and the impingement that's occurring is right in through here. So you get that posterior capsule back behind here pushing it forward, which gives a little bit of space, so when it rotates, it pinches in there and causes pain, potentially could cause a tear. So typically the presentation with this is, you know, the shoulder hurts back in here. Now it could be a diffuse pain as well, but detecting the differences of why that shoulder hurts and what's impinging it and what structures are tight and weak is a really key point into how you're going to apply your treatment approach. Because, you know, really if there's any involvement in the rotator cuff and you strengthen it, it's going to feel better. But is it going to last if you don't address the appropriate things at that point? Probably not. So then your treatment strategies are based on what you found there and identified as being the culprit. So you target the weak musculature that you found on exam, strengthen it. strengthen the supporting musculature, the cuff, the lat, the rhomboids, anything that might be weak, or just to help support the scapula and the glenohumeral joint. And obviously, we want to work these muscles or the shoulder in a way that's not painful, because if it's painful, chances are you're causing further impingement, further damage. So maybe that means working through a less range of motion, or working those muscles eccentrically, whatever that might be. Then restoring the force couple, so not just focusing on the glenohumeral joint, but also addressing the muscles as they try and maintain that scapular position on the thoracic spine as it moves through the motion. And then as far as their exercises at home, stretching out that posterior capsule, whether it's cross arm test, or the towel stretch behind the arm, or the sleeper stretch, none of which have been studied in the literature currently to detect which one's more effective than another. But hopefully with this new method of measuring posterior shoulder tightness, you might start to see more studies out there determining which one is more effective as far as home goes to get the increased mobility in the posterior capsule. So mobilizations, what we can do in the clinic, mobilizations in combination with exercise in literature have been shown to have superior outcomes over any other treatment. Exercise alone, mobilization alone, combining the mobilizations with exercise is superior, particularly if there's tightness in that posterior capsule, as we mentioned. So your glides anterior to posterior, inferior glenohumeral joint glides. Posterior to anterior, probably not in this case, because you potentially already have a lax anterior capsule. So you're not going to want to stretch that out anymore, because that's going to cause further problems down the road. But post-operatively, at the appropriate time after a rotator cuff repair, those are appropriate. So just some diagrams here. This is a general anterior-posterior mobilization. Typically, hands would be flipped around, but for the camera view, so my back would be facing you instead, and the left hand would be performing the mobilization. This is more my preferred method, and it's the one that's been shown to be more effective at increasing posterior shoulder mobility. I like this because you can stabilize or get a sense with that left hand where that humeral head is and where you're providing this mobilization. So if depending on what part you're trying to mobilize, you can really get a feel where that humeral head is when you're doing that. So that feedback really helps me in addressing the spot that I want to address. And then this little arrow here indicates you can sort of preset before you do that mobilization a little inferior glide, create some more space in there. It's more comfortable for the patient and can be more effective too. So just a little inferior glide, and then your anterior to posterior mobilization is a lot more effective, because essentially what you're doing is you almost put them in a Hawkins-Kennedy position, which should be reproducing pain without this. So not so much elevation, and then that inferior glide can help reduce the pain and still be effective. Again, posterior to anterior mobilization, probably wouldn't be doing this one on someone with shoulder problems unless it's post-operative and they've got a lot of anterior tightness. I don't like this because it doesn't take a whole lot of force to move that glenoid too far with that. This one, however, this posterior anterior mobilization has been proven in the literature to help reduce pain in individuals who have shoulder pain, and also be effective at mobilizing the shoulder. So again, the way this is proven in the literature to be effective is first with a little bit of an inferior glide, and then posterior to anterior, sort of all at the same time. And that can be an effective way to reduce pain. It doesn't provide you a great deal of force to provide your mobilizations, but it can be helpful in reducing pain. And then inferior mobilizations to increase flexion of the shoulder. And again, force just driven inferiorly. Scapular mobilizations. There's a lot of different positions, ways to mobilize the scapula, but in this position they're side lying on the opposite, the uninvolved arm. Again, maintaining an aligned spine, hopefully, and then the patient's opposite arm, so they can relax, is either resting on the clinician's hip or the thumb is back through the belt loop, so that shoulder can really relax and they can feel supported while you're doing that mobilization. So next topic is a particular interest of mine, and that's cervical thoracic mobility, or the use of thrust manipulations of the cervical thoracic spine in reducing shoulder pain. Now, by no means am I trying to teach anyone here shoulder manipulation, but for those of you who've been trained to do it, who use it, or at least trained to do it, just kind of as a review. And I bring it up because it's a very hot topic in the literature recently. So Boyles et al. Were the first ones to put forth a study sort of linking the cervical thoracic thrust manipulations to decreasing shoulder pain. So he was able to find that cervical thoracic thrust manipulations were effective in reducing patients' perceived pain following the treatment, but not a great study, not a randomized controlled trial, just a one group pre-test post-test study, which doesn't allow for a great deal of generalizability to what you can do in the clinic. And then this year in January, in Phys Ther, Minkin and Cleland et al. Did a study again looking at cervical thoracic manipulations in patients with shoulder pain. And he was looking at reducing pain and then finding predictive factors that might be indicative of patients having a good outcome. So he's looking at developing a clinical prediction rule for individuals that would benefit from cervical thoracic manipulation in reducing shoulder pain. So what he found was that if 5 variables were present, if they had less than 127 degrees of pain-free flexion, less than 55 degrees of internal rotation, painful symptoms for less than 90 days, on no pain medications for the shoulder, and a negative NIRS test, that there was a 100% post-test satisfaction for reducing pain as measured in their study. Now, if only any 3 of those were present, it dropped to like 89%, but still pretty good outcomes. Now, that's just short term. If you've trained to do manipulations or done manipulations, it's not going to cure the problem. It's not the way to fix the problem, but it can help reduce the pain, make it more manageable, and maybe produce a little bit more range of motion, which some procedures have been proven to study. Again, not something to change the way you practice on. It was a single-arm trial in reference to the research method, so no control group. There was just a patient population, so not a randomized control trial. And without that, you can't make any inference between the treatment and the outcomes because there's nothing to compare it to. So, hopefully, there's going to be some research soon to be a little bit better and something that we might be able to do to help reduce shoulder pain. So, again, just to review some of the manipulations that they performed in the study that were shown to be effective. And this particular manipulation has also been shown effective to increase shoulder flexion. So it's called the pistol manipulation. It's called that because of the grip that you use. You form a pistol grip it would be this hand here, and spinous process aligned between the thenar eminence and these fingers here, and just above the third finger is the segment in which you're interested in manipulating. So it's not a general manipulation, it's a very specific manipulation to the stiff or concordant segment. You can't see my hand here, but it's paying particular attention to keeping the neck and cervical thoracic spine in flexion as you perform this manipulation. And the thrust is done through the clinician's sternum directly through the shaft of the humerus. The distraction manipulation of the upper thoracic segments. The previous one, the pistol manipulation, is also for the upper thoracic spine, not the mid or lower thoracic. So patient long sitting, neck in flexion, hands behind their head, laced fingers, and the clinician places their arms up around the patient's hands in overlapping hand position, and the sternum is directly in contact with the thoracic spine. You can attempt to manipulate a specific segment by rolling up a towel, placing it on your sternum, and keeping the high level of the towel just below the segment that you're interested in manipulating, similar to the pistol manipulation, the placement there of the segment. but this is almost more of a general manipulation than a specific manipulation. And then the thrust is indicated to anterior and superior, paying particular attention to keep the neck and cervicothoracic spine in flexion, not allowing it. The potential a lot of times what you see people doing is sort of this whole thing where you're kind of scooping up and back. It should be up and forward, which takes a little practice getting used to. And then the screw manipulation, and its name comes from sort of the latter part of the manipulation, using a pisiform grip. So the pisiform of both hands is on the transverse process of the segment you're trying to manipulate, and then the opposite pisiform is on the contralateral above or below segment that you're trying to manipulate. So one pisiform on one, whether it be the left side, and then another one up above. And this is all based on your evaluation prior to doing this, identifying the concordant segment and which one might be stiff or might need to be manipulated. And then the patient's asked to inhale and exhale normally. And the screw part of the screw manipulation is that you sort of wind up or take up the slack in the soft tissue as you're moving down, and then as the full breath is exhaled, that's when the force is then applied. So you take up the slack and then perform the manipulation. Other treatment methods, modalities, ultrasound. I use it sparingly, sort of patient dependent, because it's not really proven to be a great way to reduce pain or increase soft tissue extensibility or anything like that in the literature. It was just January in Phys Ther, they specifically looked at ultrasound's effect on soft tissue in the shoulder, and it was a literature review, so they gathered I don't know how many hundreds of studies, and they boiled down to only 8 that had semi-credible research designs and sampling methods and things like that. They couldn't even perform so when you do a literature review, the goal would be to perform a meta-analysis. That's the highest level of evidence you can put out there. But in order to do that, the study designs of the research that you're reviewing has to be at a certain level. And most of this literature was not at that level. So they're left with 8 studies, and I think 3 produced positive outcomes, 2 said there was no difference, and then the 3 that did produce positive outcomes, they were more involved with calcifications of the tendons, so it might be effective with that, but in reducing pain or increasing tissue extensibility, not so much. And then iontophoresis, some people use it, some people don't. If it's really painful, irritated, inflamed, it can be effective in decreasing pain. And then the old heat and ice. So whichever one feels good, right? Takes your mind off the pain. And then the ultimate goal is same as post-op and same in any case with rehab, is to get back to those functional activities, work-related activities, or return to sport, making sure that they don't fall back into those patterns, or they might have different patterns in the sport or activity that they're doing that didn't present themselves in clinic until they went out and tried to do it. And then you address those, trying to have them reproduce that in the clinic, and even create exercises that sort of mimic those specific things that you're not going to find in a VHI catalog to print pictures of, but things that you make up with the patient that are specific to them and their needs and what it is that they're limited in or weak in, related to their functional activity or their sport. So you also want to leave them with some sort of maintenance program, if you will, following their stint there, because your hopes are that they don't fall back into the same pattern that they did before. So say they've got a bone spur and the cuff's weak and you're getting that impingement and the bone spur is digging into something. You strengthen the cuff, you realign, you restore that force couple in there. Everything's great. Bone spur's still there. So they go out, they don't do their exercises, they come back, my shoulder still hurts. Have you been doing your exercises? No, I felt better, right? So educating them about the importance of that, and also addressing things early on in the examination that dictate the treatment, and not just, it's a rotator cuff tear, rotator cuff pathology, we're going to do this mobilization, strengthen this, stretch that, but really being picky early on in the examination, spending the time to find out what's going on and then addressing it appropriately. And yeah, that's it. So references. Thank everybody for coming out. So